to Psychiatry Boot Camp. Today we are talking about a controversial topic, even for this podcast, physician-assisted suicide. And I have to say, I did an incredible amount of prep for this episode, and I think that comes through both in terms of the depth and the breadth of the information that we're able to cover. That said, we had to limit ourselves to about an hour, and I want to lead with a couple of key points so that we can dive right in. First of all, the human suffering at the heart of this topic is immense. People who are considering suicide as an alternative to being alive are virtually by definition experiencing life's most difficult situations and deepest forms of suffering. One area where physician-assisted suicide often comes up is in patients with severe dementia. Alzheimer's runs in my family. It's not lost on me how much suffering dementia causes, not only for a patient, but for their entire support system. My heart goes out to people who find themselves in situations where they are considering physician-assisted suicide. And my intention with this episode is not at all to discount the severity of this suffering or the sanctity of this very, very personal choice. I chose my guest carefully for this episode. I needed a guest with a wealth of experience and qualifications in medical ethics, and someone who would be able to articulate the complexities of this topic well. I also didn't want to sterilize the topic. I'm bringing you a guest who is a talented orator and who delivers information with passion, authenticity, and emotion. This is intentional, and I'm proud to be standing for something that I believe in throughout this conversation. I did step out of the unbiased host role and let my cards show a bit on this episode, so I hope the authenticity makes for a compelling listening experience. Finally, I want to name what I perceive to be the knife's edge of the argument that I've heard Dr. Komrad make in the content that I studied to prep for this episode. There is an argument here that can accept a person's right to bodily autonomy up to and including suicide. But what Dr. Komrad does not accept, and what I do not accept, is the argument that physician-assisted suicide should be brought into the house of medicine as a valid medical treatment. Dr. Komrad sees our role as psychiatrists as people who can prevent suicide, people who have a specialized skill set to help people find meaning in life, and people who should not aid, abet, or provide suicide. And we should be leaders, teachers, and exemplars of that ethos in the house of medicine. Dr. Komrad, welcome to Psychiatry Boot Camp, and I will ask you to introduce yourself to our audience.
I'd be glad to, and thank you very much for inviting me. My name is Dr. Mark Komrad. I am a psychiatrist based in Baltimore. I did my training here at Johns Hopkins, and I spent many, many years helping to run the treatment-resistant psychotic disorders unit at Sheppard Pratt Hospital, which is the largest nonprofit hospital system in Maryland, and actually really in the tri-state area here.
Thank you for that introduction. And you have been very prolific on this topic of physician-assisted suicide. I've had the opportunity to review a lot of your work on the topic. You're a very gifted orator, so I did not know that you had a radio show, but it does not surprise me. I'm going to start here with an Orwell quote that you actually presented in one of your previous works on this topic. The Orwell quote: "If thought corrupts language, language can also corrupt thought." So I think that the words we use and the particular words that we use to describe certain phenomena can inform the way we conceptualize those phenomena. And I start with this because it's immediately clear to me when encountering the topic of physician-assisted suicide that there's a range of different phrases that people use to describe similar phenomena. Physician-assisted suicide is one phrase people use, but also physician aid in dying, medical aid in dying, death with dignity, and euthanasia. Can you compare and contrast these terms for us?
Yes, indeed. I think that's a very poignant quote. So many topics these days, it's about how you language it. And particularly those in power may want to both deploy certain languages as well as censor other kinds of languages. We're certainly seeing that in the terms of the U.S. government today. So language is quite important, not just in terms of how we talk about it, but also how we educate people about it. It turns out the language that you use when you do polls about these things, depending on how what terms you use, can create very significant differences in the outcome of those polls. There's actually been some interesting research studies. So let's talk about some of the fundamental terms here that have become terms of art. First of all, let's simply start with the term palliative care, which has to do with people who are suffering at the end of life, not necessarily strictly at the end of life, is about trying to bring to bear the state of the art for relief and comfort and even to help people find meaning with their suffering. But especially when it comes to terminal illness, to get out of the way of death while providing those things. And that has, for some time now, been a state-of-the-art ethically understood and utilized practice in medicine. Then the next level that we should talk about is called physician-assisted suicide. And in that, a physician, although in some jurisdictions, a nurse practitioner and other mid-level, interestingly, provides under certain conditions a written prescription that a patient takes to the pharmacy and gets a collection of lethal medications that are designed for the purpose of creating death, and they self-administer those orally at the time and the place of their own choosing, typically, with or without witnesses, because most jurisdictions that permit this don't require any witnesses at the time or even the presence of a physician. Those medications often are tucked away in the closet, hopefully not discovered by your suicidal granddaughter someday. Sometimes they may sit around for several years, as has been documented. But this is a self-administered oral regimen. Often involves a box of barbiturates and digitalis and tricyclics and a number of other things. So that's physician-assisted suicide. Now, I want to say that term, which actually covers the techniques that are allowed in some states in the U.S., which we can get to, has been challenged. But the American Medical Association, on 5 separate occasions, has considered whether alternative words besides suicide should be used, and we should talk a little bit about why it might be important. But just to say at this juncture that the AMA has 5 times said that should be the preferred term. It should not be called aid in dying. It shouldn't be called death with dignity. The preferred term, and the AMA uses and suggests be used, is assisted suicide. And then the most ethically difficult and controversial method is called euthanasia. And I want to tell you that outside the United States, euthanasia, as I'm about to describe it, is the most commonly used procedure. Euthanasia is where the clinician starts an intravenous line and administers a lethal injection at the bedside of the patient, just like a lethal injection in jail, for people with the death penalty. So that's euthanasia. In most countries of the world outside the U.S., as I've said, typically both physician-assisted suicide and euthanasia are available when it's legalized. But in the vast majority of cases, given an opportunity to outsource the suicide to a physician, almost everybody prefers to do that. And we typically see a ratio of 99% of the cases are euthanasia and 1% assisted suicide in those places where both are an option. So those are the basic terms of art.
So much you said that I want to tug on those little threads. There's a lot to unpack here. I've covered this topic a few times throughout my education. So I remember in my social justice class in medical school, we talked about euthanasia, physician-assisted suicide. I remember in my bioethics class in undergrad, we talked about this. We talked about it in medical school again in bioethics. Really interestingly, this topic didn't come up one time in my 4 years of psychiatry residency. But I've always sort of enjoyed discussing it from an abstract academic lens, and this topic always seemed somewhere else. It seemed like it was in a fictional, futuristic novel or something that some particularly progressive folks were doing in Denmark, but not something that was going to happen right here in the state of Missouri.
Or out of movies like Soylent Green.
That's right. That's exactly right. How common is this practice? How widespread is it? Is it getting more popular or is it getting less popular?
It's getting increasingly popular. In fact, I would go so far as to use the metaphor, a metastatic spread of this idea and its legalization. The countries that have been at this the longest, I would say the living laboratories in which this experiment is running, where there's so much to be learned from, are the Benelux country, Belgium, Netherlands, and Luxembourg, particularly Netherlands and Belgium. They opened this in 2003, these procedures. And interestingly, from the get-go in those countries, they basically got out of the domain of terminal illness. And rather than focusing the eligibility for these procedures on terminal illness, they focused it on suffering. So in those countries, you do not need to be terminally ill. You just need to have a condition that you yourself can convince your physician that you are unable to suffer it, that it is insufferable, and that you and your physician have agreed that there are no appropriate, acceptable means of further relieving your suffering. So that opened it from the get-go to chronically disabled people, not people necessarily who are terminally ill, and because as we psychiatrists have long been trying to achieve parity, we have long said that our patients should be considered like any other medical patients, and that psychiatric suffering should not necessarily be considered necessarily inferior or different or of a different kind to physical suffering. So once you have the formula of irremediable suffering rather than terminal illness as the criteria for eligibility, that opens it up to people with psychiatric disorders only. So in the Netherlands and Belgium, there have been quite a few patients with psychiatric illness who have been euthanized. And both these countries have euthanasia as their predominant thing. So at this point, as of the end of 2024, the 2025 data isn't in, there have been over 107,000 people in the Netherlands who have died this way, and over 37,000 people in Belgium, a smaller country. In the Netherlands, between 6 and 10%, so between 6 and 10 out of every human being who dies in that country dies at the sharp end of a doctor's needle deliberately. In Belgium, it's about 4% of all deaths are by euthanasia. Now, Canada comes along, a much bigger country, in 2016. And Canada opens it up to people, and they came up with a unique Canadian term, people whose death is, quote, in the reasonably foreseeable future. That was not statutorily defined. So you can imagine how wide one can interpret reasonably foreseeable, but it was felt to be tethered somehow to the end of life. That was until 3 years later, when they widened it and they took on the same model as the Netherlands and Belgium. Rather than talking about death in the foreseeable or terminal illness, they too decided suffering would be the key to the opening the gate, and the same criteria that you saw in the Netherlands and Belgium opened to in Canada, so that chronically disabled people. And what's interesting is if you were terminally ill, once they widened it, if you were terminally ill, you could get your euthanasia the same day you requested it. If you were chronically ill and not terminally ill, now you have to wait 90 days to get it. But they explicitly said no psychiatric patients until March of 2027. And in March of 2027, Canada intends, statute by law, has told psychiatrists to get ready, get your criteria going, because we will let people with psychiatric disorders only be eligible for euthanasia. It's predominantly euthanasia in March of 2027. So because Canada is so large, it's been really taken off. So basically, there have now been in the merely in the first 8 years, they have had nearly as many cases as the Netherlands took 20 years to have. So Canada is up now between 90 and 100,000 deaths. And again, in Canada, about between 5 and 7 out of every 100 people in Canada now die by euthanasia. In fact, euthanasia is now the fourth leading cause of death in Canada. And then finally, here in the United States, we had 12 jurisdictions until this year, when Delaware became the 13th. And just in the last week, New York and Illinois just had their governors sign their statutes into law. So we've been having it. The first one was Oregon back in 1998. California, came on around 2018. And here in the United States, we only have physician-assisted suicide, and we only have it for terminal illness. However, let me say a word about terminal illness. What's fascinating is that these laws have effectively changed the definition of what terminal illness means in the context of these procedures. We physicians have long come to understand and utilized in our common parlance the term terminal illness to mean an illness that somebody will probably die from within 6 months, given even in the face of state-of-the-art treatments.
Agree.
Right? These laws, however, here in the U.S., basically have changed that. They said terminal illness, for the purpose of being eligible for your box of barbiturates, means simply that you will die within 6 months, not just if state-of-the-art treatment doesn't work, but you can refuse whatever you want. So within treatments that you find acceptable. So for example, if you have end-stage renal disease and you do not want to have dialysis, or you don't want to get on the transplant list, you have now created for yourself a terminal condition. And that's fine according to the laws. So terminal illness becomes not something that is futile in terms of what the state-of-the-art medicine has to offer, but terminal illness is now in these statutes basically becomes whatever the patient is willing or unwilling to do. So it's a full autonomy paradigm. It's not about so much medical criteria, because in the end, the patient themselves can produce a terminal condition.
Yeah, I mean, that seems like it's a common thread through every country and every set of language, every system that you just walked through. I'm seeing a lot of strategic ambiguity here on behalf of policymakers. An insufferable condition with no acceptable means for remedying it. That's going to mean different things to different people. And I guess, how can you know what someone's internal experience is like? You probably just have to take their word for it in most cases. And what's acceptable to one person might not be acceptable to another. So I definitely appreciate that strategic ambiguity. That being said, these seem like really important decisions, and ones around which we should have certainty that the person is in the situation that is prescribed by law and has the full capacity to make that decision. Tell me about who it is that is making these determinations as to whether or not someone has an insufferable condition, how they go about deciding if there is an acceptable model for remedying it, how this person decides if this person does have it, if the patient does have a disease that will lead to the end of their life in the reasonably foreseeable future. What do these evaluations look like?
Yeah, I wish I could tell you that there was a standard, a universal standard that was followed by all physicians, or indeed standards that have been articulated by scientific research, by agreed upon medical societies and organizations. In point of fact, there's been a widespread failure to systematize and figure out exactly what those criteria should be. And as a result, it is left to the discretion of the individual physician who's evaluating. Now, in all these jurisdictions, there's typically 2 people who evaluate. By the way, those 2 people could be in practice together, not necessarily independent. It could be partners in the same practice. At least one of those 2 people can have as their specialty administering these either prescriptions or injections, and has attracted an enormous amount of zealotry. I mean, the interesting thing is that I have here some data from Oregon. So in Oregon, there are about 6,500 doctors in Oregon. This is for 2022. Only 146 doctors, 2%, wrote all the lethal prescriptions in that state. Most of those doctors only wrote one or two and found it actually traumatic and difficult and stopped writing it. However, one doctor wrote 51 of those prescriptions that
51% or 51
51
prescriptions?
prescriptions, 12%. And 1/3 of all the prescriptions were written by only 4 doctors. We see the same thing in Canada. I have this guy here. This guy here is in Ontario. Dr. Eric Thomas. I think he holds the record in Canada. As of April of this year, he euthanized, and remember, it's euthanasia there, so started an IV and pushed a lethal injection on 577 people. In Canada, there are over 19,000 doctors. In 2023, only 361 actually prescribed euthanasia.
Yeah, gotcha. So where I come from, working on a CL service with this is, I think about decisional capacity, and my listeners are really generally pretty comfortable with this. We've had 2 episodes on decisional capacity. We have a 3rd planned. We talk about the Applebaum-Grisso criteria, et cetera, et cetera. One thing we talk about is the sliding scale of capacity, that decisions with a higher risk-benefit ratio require a greater command at the Applebaum-Grisso criteria. And so when I think about this decision, the decision to end your life, I can't think of a decision that would fall further on the sliding scale toward really needing to demonstrate firm command of whatever criteria you're using. So I would think there's a pretty standardized capacity assessment that would be done in these patients.
There's not.
To ensure.
In fact, the American Academy of Forensic Psychology has a 16-page template for capacity assessment. Of course, that was developed in the context of things like capacity to stand trial, the right to refuse surgical treatment, to write a will, and so forth. Nobody has ever articulated capacity assessment under these circumstances. If you look at the Oregon form that physicians fill out, there's a little checkbox that says, I have found that this person has capacity to consent to this procedure. Check. No guidelines, no template for the evaluation of that. And moreover, let me just say, Mark, that I consider capacity to be a highly specialized skill set. In fact, I think it's a skill set that most psychiatrists are actually not experienced with, even necessarily trained with. I think that it's a subspecialty skill set that is typically deployed by 2 subspecialties in psychiatry: forensic psychiatry and CNL psychiatry, right? The vast majority of people who are doing capacity assessments out there in the world of euthanasia and assisted suicide are primary care physicians, oncologists, surgeons who, as I say, have no training in this. I am neither a CNL psychiatrist nor a forensic psychiatrist. Even though I have 35 years of experience as a clinician, I personally do not feel qualified to do an ordinary capacity assessment for one of these other applications that we discussed, let alone for a procedure that I can't even give appropriate informed consent about because I can't tell them what's on the other side of this intervention.
So there's no tracking of how thorough the decisional capacity assessments are for these patients.
Right. And in fact, studies that have been done in Europe, in Belgium, for example, have shown that when you actually review the criteria that were used in a select cases that were studied, that less than half of them had what a capacity-trained psychiatrist would have considered an adequate assessment of capacity. But good enough because it's left to the discretion. So we're back to the original question, which is, how are they deciding? And the fact of the matter is, the bottom line answer to that is, doctor, whatever your training has given you to evaluate whether a person understands what you're saying to them. Whatever you usually do to do that, just do that.
And it's basically straight from policymakers.
Yes.
Yeah. Before the break, I am going to ask you, you're clearly an advocate in this space, and I'm going to ask you to slip on the role of devil's advocate just ever so briefly, even if it's uncomfortable for you. I think this practice is pretty foreign to most mental health practitioners in the United States. I think preventing suicide is central to the ethos of being a psychiatrist. And so talking about inducing suicide or promoting suicide,
Providing suicide.
providing
Or even
suicide.
in the cases of euthanasia, administering suicide or giving a patient a chemical gun with which to implement it.
So some of our listeners might even be bored by this because it's so clearly a bad idea in their opinion. But how are the psychiatrists who are providing euthanasia or promoting suicide rationalizing this to themselves? What would they say about why they feel this is an ethical practice?
Right. And I do want to point out there are actual psychiatrists who are doing this in Belgium and the Netherlands. Psychiatrists don't usually get involved in non-psychiatric cases anywhere, but with the in those jurisdictions where they do allow psychiatric patients, turns out about 8% of psychiatrists are willing to do this. And
Are
in
not
fact,
just doing the assessment, but actually killing the patient.
right, given the shot. Indeed, there is a specialized clinic in the Netherlands called the Euthanasia Expertise Center, or in Dutch, the Levenseinde Clinic, that does the majority of psychiatric cases, because a lot of people just don't want to touch psychiatric cases. And the people who are working in those clinics are to do the psychiatric patients are psychiatrists. So, remarkably speaking, but by the way, more psychiatrists approve of this than are willing to do it. I have one colleague who wryly says, a lot of people want hamburger, but very few people are willing to kill the cow. Uh, but the fact of the matter is that even where psychiatrists support this idea, they're not willing to do it themselves. And so what are the arguments in favor of it? The arguments argue as follows. First of all, they argue from the position of parity, which we talked about before, right? And that is, if indeed your society decides that somebody who's not necessarily terminally ill, and we do need to talk about the issue of terminality in psychiatry, because that's coming up, especially here in the US now, where you have to be terminal. But in Belgium, Netherlands, soon in Canada, our patients basically deserve the same privileges and opportunities. Indeed, the Canadian Psychiatric Association, who supports this eventuality in Canada, has said that it is unjust and discriminatory to not include psychiatric patients. But whether they're psychiatric patients or not, the idea is that this is about the right to self-determination, and that if a person wants to do this, they should. And say those who argue in favor of this, including those psychiatrists that do, they say that under these circumstances, we should not call this suicide. So we're not actually providing and administering suicide. They're saying this is something else. This is not suicide as we have traditionally understood it. These people don't really want to die. Instead, they just want to end their suffering. And that in the interest of, which I think is a misinterpretation of the Hippocratic dictum, do no harm, that if the only thing we can do to end suffering is to end the sufferer, that we should basically provide an end to the sufferer to end the suffering. So that's one aspect of the argument. By the way, I want to say on that point that for a while, the American Association of Suicidology maintained this separate, these two different kinds of suicide, right? The one thing that we traditionally call suicide, and the other that's not suicide, that's, aid in dying. The suicide that we should prevent and the suicide we should provide. And the assumption was that it's possible to distinguish those two. Well, as it turns out, the more one looks into this, the more one encounters this, it's actually not possible to distinguish those two different kinds of suicide. One which we call a pathology that we should intervene with and prevent, and the other that we should call a right that a patient has and provide a medical procedure to administer it. So after maintaining this separateness for a couple of years, even that organization decided, you know what, we can't make an adequate case for that. And they retired that position that said these two things should be separate. And, we'll get back to you once we figure out how we can distinguish those two. So that was a very, very significant reversal. But again, those who believe this say, no, we shouldn't be using the word suicide. This isn't suicide. This isn't a pathology, that we are basically giving patients the relief that they are seeking.
So we're looking at autonomy, we're looking at parity, we're looking at patient choice, we're looking at freedom, sort of, would be the main principles.
Yeah, but here's the thing, is that it's initially promulgated as a right or a freedom, that, you should be free to choose this. But what happens is what starts off as a freedom becomes converted into a right. And whenever you have a right, then there's a duty for somebody to fulfill that right. And not just a duty to fulfill it, not just a possibility, but the obligation to institutionalize it, to regularize
to facilitate it. Yeah.
Right? Let's set up systems. Let's set up trainings.
It's a dirty job, but someone's got to do it.
Let's have the National Organization of Aid and Dying Physicians, which there are now several. Let's have specialties. Let's have places like in Canada, they have the MAID House, the Medical Aid and Dying House, and the Euthanasia Expertise Center in Netherlands, so that once something moves from being a freedom to a right, and then the duty becomes assigned to who? It becomes assigned to physicians. And when it's assigned to physicians, when we think about this is a very fundamental change in the nature of civilization, to basically designate, not in wartime, but one group of human beings who are authorized to kill another set of human beings. And of all people given that privilege, physicians, this is anathema to the venerable history of medical ethics.
Dr. Komrad, I'm going to stop you right there. We need to take a quick break. I think you're on a roll here. When we come back, we're going to talk about specifically psychiatry patients and what diagnoses are most often used. We'll talk about the idea of terminality in psychiatric illnesses and many more cogent points from Dr. Komrad ahead after this quick break. I think for most people who go into psychiatry or therapy, running a business is the last thing they wanted to do. But then we come to find out that for us to have a practice that is thoughtfully built to give our patients enough of our time and expertise, we have to develop our business and organizational skills just to make it work. If you're hoping to simplify the business side of your practice, Simple Practice is the tool for you. Simple Practice is an all-in-one EHR that is HIPAA compliant, high trust certified, and built specifically for therapists. Simple Practice brings scheduling, billing, insurance, and client communication all into one place so that you're not juggling multiple systems throughout the day just to run your practice. Simple Practice makes documentation less daunting and less draining so you have more time and energy to give back to your patients. And if you're just starting out or growing your practice, there's also a credentialing service that takes the headache out of insurance enrollment, which honestly can be a huge lift. Simple Practice is trusted by over 25,000 health and wellness professionals, and you can feel that it is thoughtfully designed for our work as psychiatrists and therapists. If you are ready to simplify the business side of your practice, now is a great time to try Simple Practice. Start with a 7-day free trial and then get 50% off your first 3 months. Just go to simplepractice.com to claim the offer. Again, that's simplepractice.com. As a podcast listener, you know that podcasts are perfect for adult learning. Adults know what they need to learn and they know how they want to learn it. And for me, when it comes to studying for board and licensing exams, there is no substitution for doing multiple choice questions. If you are studying to beat an exam, I think you should use Beat the Boards. Right now, Beat the Boards is offering bootcamp listeners a great deal. You'll get free access to over 4,400 exam-style questions for USMLE Step 2 and over 4,500 questions for USMLE Step 3. Again, this is not a discount code. These exam questions are totally free for bootcamp listeners. I use Beat the Boards to study for my own board exams, as well as several other services similar to this, and I really did find that Beat the Boards was the best by far. Go to beattheboards.com/bootcamp to sign up and get your free questions. That's beattheboards.com/bootcamp. Hey, Bootcamp listeners, I want to talk to you about Cozy Earth because Cozy Earth is ruining my marriage. When my wife or myself slips into a Cozy Earth product, what we find is that we are functionally paralyzed for the rest of the evening, leaving the other person as a single parent for the time being. These products are so comfortable, you can tell that they are obsessively engineered. And I thought that I knew something about socks and comforters and blankets, but until I tried the Cozy Earth version, I realized that I really didn't know anything at all. Cozy Earth stands by their products with a 100-night sleep trial and a 10-year warranty, which is pretty crazy. And if you go to cozyearth.com, you can use my code BOOTCAMP for up to 20% off. If you get a post-purchase survey, be sure to mention that you heard about Cozy Earth right here on Psychiatry Boot Camp. Experience the craft behind the comfort and make every day feel intentional. All right, welcome back to Psychiatry Boot Camp. We're with Dr. Mark Komrad. We're talking about physician-assisted suicide. Dr. Komrad, in my mind, physician-assisted suicide and euthanasia are really more of an extension of palliative care, right? The state of the art in hospice is really to get out of the way of the dying process, not to accelerate the dying process. But I see this as sort of one step further and actually accelerating the dying process to alleviate suffering. To me, it kind of belongs in palliative care, but it sounds like it's creeping into psychiatry.
Well, Mark, I just want to say in response to that, most of the world's major hospice and palliative care organizations disavow this as part of palliative care. I mean, there's enough trouble convince people to get into those kind of services without them thinking the doctor is going to kill them or offering them death. So, and in fact, there's quite a trove of palliative care nurses in Belgium who have left the field because of the attempt to shoehorn euthanasia into palliative care. So most palliative care professionals actually reject that this is part of palliative care.
And I'm not even going to get you started on organ donation yet. So let's talk about psychiatric diagnoses. What psychiatric diagnoses do you think are most commonly used for the psychiatric diagnoses that are being used to justify this procedure? And Dr. Komrad, since we have a psychiatric audience, I'm going to ask you to dive a little bit into how countertransference and projective identification might play a role in these decisions.
Oh, good. Thank you, because that's something very, very important. And typically having to define those things for most non-psychiatric audiences is difficult. First, about psychiatric diagnosis. So if you look in Belgium, we've had about 750, and in Netherlands, a total of 1,100 psychiatric patients now over the course of their time who have received euthanasia. So the most common diagnoses are mood disorders, okay, but a variety of other things, including psychotic disorders, which actually boggles my mind about how people with psychosis could be considered to have, capacity to consent to this, but also eating disorders, autistic spectrum disorders, PTSD. But here's the thing. I'll tell you the most common psychiatric diagnosis, often in comorbidity with others, sometimes by itself, personality disorders. And this audience, I'm sure, will not at all be surprised to learn that the most common type of personality disorders is borderline personality disorder, that which carries chronic suicidality as a way of coping with distress. And in both Belgium and the Netherlands, 50% of cases have a personality disorder either solely or in comorbidity. And here's the amazing thing. Only 1/3 of those patients who've had personality disorders have ever had any psychotherapy. I think we could all agree that psychotherapy is a sine qua non of treatment for personality disorders, and yet only 1/3 of them have actually had psychotherapy. So that's really it's both amazing and at the same time not entirely surprising. So that's sort of who's getting it. I also want to say that eating disorders is an emerging thing. And this actually has been stirred up quite a bit of controversy. And let's start here in the U.S. with this. So in Colorado, there was a now infamous paper, a paper that a group of us, including Paul Applebaum, by the way, are trying to urge the journal to retract. But 3 patients in Colorado were deemed terminally ill. Because remember, here in the US, got to be terminally ill. So 3 patients were deemed to have terminal anorexia, which is not a accepted construct, that their condition was considered futile, and that since the patients were resisting treatment, and frankly, why were they resisting treatment? Because the illness itself
Because they have anorexia.
was impeding the treatment, but they were considered to have full capacity, and that because they wouldn't cooperate with treatment, terminally ill. All 3 were given lethal medications to end their lives by their treating physician, and 2 of them used it, and 1 of them died before she could use it. Meanwhile, since those cases have come up, I've had colleagues said that now some defense attorneys in involuntary commitment hearings for anorectic patients are citing that paper and saying that assisted suicide is the least restrictive alternative. Remember, that's always a criteria for involuntary hospitalization, that it's a lesser restrictive alternative than involuntary hospitalization. And we've now documented 66 cases around the world of so-called terminal anorexia that have been euthanized or given assisted suicide. And there may be a lot more because there are cases both in Oregon, Washington, and Colorado where the diagnosis at the time of death was listed as severe protein calorie malnutrition. And we believe, can't get access to those records because of HIPAA, but we believe that many of those cases, the real diagnosis was anorexia. And instead of putting a psychiatric diagnosis, they put a medical diagnosis.
Dr. Komrad, tell me, so first of all, I have never dropped an F-bomb on Psychiatry Boot Camp. I consider it unprofessional. But what I will say is that having the most popular psychiatric diagnosis used for euthanasia being borderline personality disorder, and knowing that, was it only a third of those patients have even tried any form of psychotherapy before they're killed?
That's what the data from Scott Kim shows.
Yeah, that's fucked. Can you tell me about the countertransference and the projective identification?
Right. I'm glad. Thank you for coming back to that. So, as we know, as psychiatrists, there's a complex dynamic that happens between doctor and patient, right? So that the doctor's own issues, first of all, countertransference, the doctor's own issues and discomfort with the patient, the doctor's own exhaustion. I mean, if you haven't yet been exhausted by a patient with chronic suicidality or self-harm or any one of a number of other symptoms, if you haven't been exhausted by a patient, then you haven't been a psychiatrist long enough, right? It'll eventually happen. And imagine if you now live in a jurisdiction where one potential treatment plan is that we can put on the treatment plan suicide as something that I can aid and abet you with. So my own discomfort with you, a difficult patient, you an exhausting patient, you a patient who's constantly calling me and keeping me up in the middle of the night, okay? Not to mention my own personal experience with perhaps a mentally ill parent that I grew up with, right? All that background material that goes into countertransference. Now, projective identification. So projective identification, which is, a dynamic that adheres to some extent in all relationships, but particularly in highly emotionally charged relationships, is where a patient basically works unconsciously on the treater to produce in the treater the very feelings that the patient is having trouble coping with. So that's the projection part. Okay? Then the identification part is seeing how you, the treater, cope with it. Okay? So I'm feeling hopeless as the patient. I'm working on you unconsciously. And pretty soon you're feeling hopeless with me. Now, your hopelessness at this point is my hopelessness. That's where it comes from. Okay? And now I need to see how you deal with the hopelessness about my case, right? So if you're giving in to the hopelessness, it's basically my hopelessness. You are colluding in this dance of projective identification. You are colluding with my hopelessness, right? And rather than trying to accompany me on the journey out of hopelessness and help me find that path, you are actually feeding my hopelessness, not just acknowledging my hopelessness, but you are satisfying my sense that it is hopeless and fruitless by providing me a chemical gun or approving me getting that IV.
Thank you. I think that was extremely concise for us and very compelling. I heard you talk about that somewhere else when I was prepping for this episode, and I have to say, I've never heard it put so bluntly that sometimes you're sitting with a patient that you know very well, that you care about so deeply, and they're telling you for the 200th time how suicidal they are, and you might have a stray thought that says, if you're so suicidal, why haven't you done it yet? Why don't you just go do it? And to say that that thought isn't crossing your mind, first of all, if that thought isn't crossing your mind at some point, you're not working hard enough. You're not trying hard enough.
Right. Or you haven't had enough experience yet with
Right.
patients.
Let's be honest, right? And if you're in a position to be treating these patients, you should have seen other patients where you've had this countertransference. And I just can't imagine if that option were on the table and your patient were begging you for it, and your goal is to alleviate suffering. It just twists my gut in knots. Can you walk me through? I know you've been involved in policy on this issue, a lot of advocacy, but specifically position statements and votes that have happened with organized medicine organizations. Can you tell me about the policy standpoint from the American Medical Association and the American Psychiatric Association on this issue?
Right. So the American Medical Association, the AMA, I think I alluded to this earlier, has met on 5 separate occasions with their House of Delegates. And they have a statement that says physician-assisted suicide and euthanasia is fundamentally incompatible with the physician's role as a healer, would be difficult or impossible to control, and would pose serious societal risks. That was first crafted in 1994, reaffirmed in 2009, 2019, 2023, and again just this past June in 2025. And again, as I said before, they also affirmed that the appropriate term should remain assisted suicide and not other terms. So remember that the original foundation of medical ethics was the Hippocratic Asclepion. In ancient Greece, euthanasia was not that unusual. There wasn't that much that you could often do for people. But what differed the Asclepion of Hippocrates was it was the only place where, first of all, in order to become a student there and to practice there, you actually had to evince a set of values. The only Asclepion. In fact, you had to take an oath. And one of the key phrases of that oath, why key? Because it distinguished that value from all other Asclepia, was, I will not give any man a poison, nor instruct others how to do so. And that was the root from which the mighty tree of medicine has grown over the millennia, the boards of which have built the house of medicine. So that dictum has been a through line as civilizations have come and gone, governments have come and gone, wanting various things from physicians. So the AMA and the World Medical Association, which also has a very strong statement against these procedures. They say we're firmly opposed to euthanasia and physician-assisted suicide, have been the contemporary keepers of that code. Now, the American Psychiatric Association, our code is built on top of the AMA code. In fact, the formal name of the Code of Ethics of the APA, and remember I was on the ethics committee for 6 years, is the AMA Code of Ethics with special annotations for psychiatrists.
I'm a big fan of the Goldwater rule. I've done a lot of work on that, so I'm familiar with the code.
and I was on the ethics committee at the height of the recent controversy in recent years about this. So we follow the AMA. However, we have we crafted, and I helped to craft this with colleague Ann Hansen, the position statement that was written especially for Belgium and the Netherlands and Canada and any other jurisdiction that wants to consider our folks and in general those who are not terminally ill. So the APA statement, which was, by the way, voted on unanimously by the Assembly, not a single dissenting vote, not a single abstention. The APA position on this is that the APA opposes legislation that permits physicians to prescribe or administer an intervention for causing death to persons seeking assisted death solely for mental illness. It's the position of the APA that psychiatrists should not prescribe or administer such interventions. So we wanted to just be heard loud and clear for the benefit of our particular patients.
Not permitting it in other cases, but just being especially specific that we have thought through this issue, we have discussed it as a committee, we have voted on it, and there is no universe in which the APA would support physician-assisted suicide for patients with a primary diagnosis of a psychiatric disorder.
It wasn't just the ethics committee voting on it, it's the entire APA assembly and the board of directors. I mean, that's how position statements, are made. So, right. So it shouldn't be used to imply that we're okay with other ones, but we want you to hear us about our guys.
Gotcha. Okay, so let's talk about if this is, and this is, becoming much more widespread. It is spreading across the United States even now. I imagine there's some listeners that are confused about, or maybe I should say concerned about, how this will affect them or how they will be expected to behave if this is legalized in their jurisdiction or if it already is legalized in their jurisdiction. Tell us about conscientious objection in this realm. How have conscientious objectors been handled in other countries, in the countries where this is a longstanding practice? How have conscientious objectors been dealt with in the United States? Any guidance you can give us there?
Well, let's start off with the country that's had the most difficulty with this, which is Canada, right? In Canada, which now is the most active euthanasia regime in the world. We're talking, last year, over 16,000 people euthanized. Although they purport to have conscientious objection, nevertheless, a doctor must be at least part of the chain of culpability. So there it is both unethical and actually illegal for you to not engage in two things. One is letting a patient know, give informed consent that you might be eligible for this because, got to talk about all the medical procedures you might be eligible for.
That's your legal duty as a physician.
Your legal duty is to say you might be eligible for them. Yes.
Wow.
And secondly, if you don't want to do it yourself, that's fine. If you don't want to evaluate them or administer it, that's okay. But you must point them in the direction of somebody who would be willing to do that.
It's too bad I've used up all my F-bombs for the day.
So now they do have an 800 number that's trying to get around that, and they're advertising so patients can call the 800 number.
I think one of your points here too is their advertising. This is big business, actually, but that's probably a separate topic in and of itself.
Right.
Okay, so you're talking about conscientious objectors. So you're telling me that in Canada, it is a legal obligation of a physician to let a patient know if they might be eligible for this. And if the physician is not willing to participate in this chain of moral culpability, the physician is legally obligated to point the patient in the direction of someone who is likely to participate in this. Is that correct?
That's correct.
Wow.
Then in the Netherlands, they have dealt with that by setting up these specialty clinics, right? So you can go to the specialty clinics. You don't even have to ask your doctor, right? You can just go knock on the door of the Euthanasia Expertise Center.
So they're actually okay with conscientious objectors because it's so common that it doesn't matter.
So they've created, plenty of enthusiastic, and as a matter of fact, even the psychiatrists in particular who are doing psychiatric euthanasia in these specialty clinics in Netherlands, I think one of them said, "We're doing God's work." They're, again, very proud. They feel that they're vanguards at the cutting edge of, a new and highly virtuous moral structure there.
Just like the lobotomy.
Yeah, yeah. In America, especially, certainly we've had plenty of experience here with other controversies like abortion and gender-affirming care and so forth. I think that we have much more rigorous protections. And in fact, there are government protections for some of those things. And those are now applying where assisted suicide is legalized to that as well, that protect physicians' rights. But I will tell you that it's become, in many countries, it's become a litmus test of whether or not you could be hired, whether or not your contract can be renewed. I mean, here is testimony before the Canadian Parliament from a physician who said, "At my institution, physicians are being bullied into accepting the role of being involved with MAID, which is what they call it there, medical aid in dying. This forces physicians to be legally responsible for the MAID even when it goes against their conscience or religious beliefs if they want to keep their jobs." It gets worse. At one of our staff meetings, a psychiatrist actually stood up and announced that any physician who didn't actively support MAID shouldn't be working at our hospital. There's horrendous stress at our hospital. Physicians are afraid to speak up, afraid they'll lose their jobs if they say anything. Even just speaking to colleagues about this, we use alternative email addresses and speak in code. We feel sometimes like we're in some sort of dystopian novel. That's the atmosphere, the cultural change and the pressures that are developing in these euthanasia-friendly and active regimes.
I might set you up for a story here. So I work at a Catholic hospital. So I would think that as a Catholic hospital, especially, right, the Catholic Church has not been unclear on their stance on this issue over the centuries. Surely at a Catholic hospital, I would be very protected from this sort of government interference, right?
No. So here's the story, perhaps the one that you were fishing for. A hospice in British Columbia, I believe, basically said, we are not going to provide euthanasia. It's against our religious beliefs in our hospice. It's not going to be an alternative. And the government said, well, in that case, we're going to take away your government funding. So the Delta Hospice, it was called, said, fine, take away our funding. And they turned to private donors and they raised the money to make up for the difference. Government said, in that case, we're going to take you over by eminent domain. And they nationalized the hospice. And now euthanasia is an option at that hospice. So they couldn't escape.
Similar situation with Christian Brothers over in, was it the Netherlands?
Is in Belgium. Yeah, the Brothers of Charity. The Brothers of Charity in Belgium run the majority of psychiatric hospitals. That's their mission. Their mission is, psychiatric care. So they run both inpatient and outpatient units. And after living for 20 years with these procedures, I mean, this is what happens. The culture begins to change. You have a whole generation that grows up where this is normative. You have physicians who are new to the profession who have never known a practice of medicine in which killing the patient on request was not an option. The hospitals are run by a board of directors, and half the members of the board of directors are lay. And they decided, after some years of the Brothers Hospital saying, we're not going to provide psychiatric euthanasia, the majority lay board ruled, we're going to go ahead and do that. And we're going to open our Catholic psychiatric hospitals. We'll have the ECT suite, and across the hall, we'll have the euthanasia suite down in the basement, and we're going to provide them. Well, that sent the Pope up the Z-axis, and he said, no, you're not. And interestingly, just as that was occurring, I had been the invited guest to give the keynote address to the Brothers of Charity hospitals in their annual meeting, where they were all agog about this. And ultimately, the Pope said, if you're going to do that, then you're going to need to take the name of the Catholic Church off your hospitals, that we don't want you to have any association with the Catholic hospital. You're going to have to rename your Catholic hospitals as something else, because if you're going to do that, we want you to dissociate from us. And that's what they did.
One of my firmly held beliefs is that culture eats religion for breakfast. And I think this is a really good example of that.
By the way, that's new. I think for many millennia, religion ate culture.
I think that's a fair take. And I think that that's a fair take. So you have talked a lot about sort of the slippery slope of euthanasia, right? So one example there would be that where physician-assisted suicide is available, euthanasia is sort of the natural next step. And then once that's allowed, everybody seems to choose that. You've mentioned that due to the ethical principle of parity, if we're going to allow physician-assisted suicide and euthanasia for patients with medical disorders, it's not much of a jump to include patients with psychiatric disorders. Do you think that we're nearing the bottom of this slippery slope? Another way to ask this season is all about the future of psychiatry for us. So, what is the future of physician assisted suicide and euthanasia?
Right. We are not at all at the bottom of the slippery slope. And by the way, I hope that I've made it clear in our remarks, and I'm prepared to actually address this perhaps in the future, very specifically, how the slippery slope is not a theoretical concept. It's not a fear, that we're seeing this in the living laboratories, step by step, beginning with the low-hanging fruit, people who are going to die by the end of the week, eventually going to, the disabled. So where else can it go from here? Well, it is going. We are already seeing in the Netherlands, the largest political party, D66, is now pushing, and it's been pushing for a while, but it's now hot on the trail of expanding this further and actually demedicalizing it, and making these procedures available for those who feel they have completed life or are tired of living. And then what begins to happen is people begin to get to the point where it becomes not just an option, but increasingly an expectation and a duty.
Right.
I have a colleague in the Netherlands who tells me that his elderly father, who's had a chronic condition, has ceased to be able to complain about his suffering and his pain, because whenever he does, his friends say, "We don't understand. Why are you complaining? You could have euthanasia. Quit your belly aching. You could have euthanasia." 2 polls, so it's reproducible. It's been reproduced in a separate poll of Belgians who've now lived with this for a quarter century, like I say, an entire generation. 40% of Belgians now say that no Belgian citizen should be given expensive medical treatment over the age of 80.
Wow.
Because we have another alternative now. So just expensive medical treatment. So, the normalization of, and indeed the expectation that you will avail yourself of this, is what happens if this percolates for a generation. Let us learn from these living laboratories about where it goes. And, people say, well, that's their culture. This is our culture. America is different. I mean, yeah, it's Western culture, but human beings are human beings. And again, in all these different jurisdictions, we're seeing the same pattern of moving the guardrails, changing the goalpost, expanding the criteria. It may go at different rates in different jurisdictions, but the trajectory is always in the same direction, albeit at various degrees of acceleration.
I will self-disclose here that I don't know, I probably have kind of a little bit of an annoying libertarian streak in me, kind of an abstract, not very pragmatic, everybody should be able to do what they want streak. I think probably every psychiatrist has that streak in them a little bit. But where my major moral objection to this practice comes is I just don't think there's any way to safeguard voluntarism. And I think that's a big part of what you're talking about is once this cat is out of the bag, there is no way to ensure that this is a legitimate free choice that is free from any external persuasion, because as it turns out, caring for an 81-year-old with severe Alzheimer's disease is really expensive and very time consuming and does place a burden on a family and a society. And when just
and the doctors that are caring for them.
Exactly. And when just killing that person is seen as a valid and reasonable option, you know what, Dr. Komrad, just tell me the story about the patient who had a advanced directive that said if they were to develop late stage dementia, they would want to be euthanized.
This is the Netherlands.
Yeah, there's an interesting story about what happens when that actually comes into practice. I'm going to give you an open mic on that.
Yeah. And by the way, not just that it's available, but that it would be a virtue, virtue.
You must do it.
Yeah, because look at how you can relieve us of burdens, how you can give money for your grandkids' college education, and so forth.
Don't you love your family? Right.
So, this where advanced directives for dementia are allowed in the Netherlands. So, one woman who had this, by whatever criteria she had set up, it was deemed that she had now reached the point. Of course, when they went to explain it to her, she didn't understand what it was. And when they tried to, bring her in and, start the IV, she struggled and didn't want it and said, no, 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 no. They tried to sedate her by putting a sedative in her coffee, and it didn't work. So ultimately, the family gathered around with one family member on each limb and held her down while the doctor started an IV and pushed the lethal injection. I mean, such an ugly scene. And that's one of the problems with advanced directives, something which, by the way, now Canada is now considering the implementation of advanced directives for dementia. Because, at the moment, if you don't have advanced directives, then you have to have capacity at the time of the euthanasia. By the way, that capacity is an interesting issue with the assisted suicide, right? Because if you can give somebody a box of lethal medications to take whenever they want, and again, in Oregon, in one case, it sat around for over 4 years, sure, you can evaluate their capacity at the time, if it's hopefully more than just a finger raise at the time of prescribing. But what about at the time of taking?
Right.
And unfortunately, there's the monitoring of what's actually happening out there in that field is minimal. It's absolutely minimal. And the questionable cases, none of them are coming up for any serious review or prosecution.
Copy that. Dr. Komrad, this has been a wide-ranging conversation. We haven't covered, I think, we've probably only covered about half of the territory that I had hoped to, just because it's so intricate and such a complex topic. But Dr. Komrad, it's been a pleasure to speak with you, and I'd like to give you an open mic here briefly if you have any final thoughts for our audience.
Yes. So I want to remind our audience that we are physicians, and that the venerable history of medical ethics has allowed us to accompany patients. Accompaniment is very important. We walk with them, and in psychiatry in particular, we have particular experience, a skill set, and expertise to take that journey with patients and to deal with complicated, difficult, suffering people. We can lead them to the edge, but we do not push them over the edge, particularly with regard to suicide. And all of these procedures amount to suicide and should not be distinguished from other forms of suicide, cannot be, and indeed may even add to suicide contagion, a whole separate session on that. But the fact is that we prevent suicide. We help people find a path to a better future. We do not provide suicide. And we have the skill set, especially a psychiatrist, to help people find that path independent of any diagnoses. Doesn't matter what or if there's a DSM diagnosis. We know how to minister to suffering, how to make meaning of suffering, how to garner support systems and resources, and to continue to accompany patients without providing, aiding, or abetting suicide, which, if we do, I think is a corruption of the fundamental meaning of what it means to be a physician, but particularly what it means to be a psychiatrist.
Thank you for that, and thanks for coming on, Dr. Komrad. Thanks for listening to this episode of Psychiatry Boot Camp. If you're enjoying the show, we'd love to know what you think. You can connect with us on TikTok or Instagram at Psych Boot Camp, or you can email me, mark@psychiatrybootcamp.com. Visit psychiatrybootcamp.com to sign up for our newsletter, and you can connect with the rest of the Human Content podcast family on Instagram and TikTok at Human Content Pods. Thank you guys so much for the ratings and the reviews. That really is the best way to support the show. And in upcoming episodes, we are going to read some of these reviews. So if you leave a review on Apple Podcasts, you may hear your review read out right here on the podcast. Full video episodes are always available on YouTube and also available on Spotify. Our YouTube handle is @Psychiatry Boot Camp. Thanks for listening. I'm your host, Dr. Mark Mullen. Our executive producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Mark Mullen. Season 4 is produced by Matthew Braddock, who also wrote this episode outline. Our editor and engineer is Jason Portizo. Theme music was generously donated by Cave Radio, one of my favorite bands. Other music is by Omer Benzvi. To learn about our program disclaimer and ethics policy, our submission verification and licensing terms, and our HIPAA release terms, go to psychiatrybootcamp.com, where you can reach us with any questions or concerns. Psychiatry Boot Camp is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.